Stanford University.
It's a course in comparative advanced healthcare systems, and the class over the last quarter has been looking in depth at 6 countries and frameworks for understanding the design of systems and the ways in which different countries have struggled first to get universal health care, which often happen in phases over many years, and then to control costs and address growing aging and chronicity. And essentially every country has had to transform their whole institutional structure from an acute hospital-based specialty system towards chronic disease management, enhanced continuity of care through primary care and things like that. We're really honored to have Professor Richard Fuchs with us today. He has received many honors from economics and from the world at large. I think we all think highly of him because he has a larger vision than most health economists. One of his first books for the general public was Who Shall Live, which is still a key question today. I understand in Don Barr's class yesterday there was a discussion about how often women should have mammograms and the trade-offs, and apparently it's estimated that it costs $650,000 to save the life of one woman. Is that worth it? So who shall live? And then he wrote How We Live and a wonderful overview of the health economy used by thousands of students over the years. And then the future of health policy. He's been president of the American Economics Association and many other things. I think it was to medicine as well.
Not president.
Oh, on the executive board? No, just a regular guy.
Just
Okay.
a regular guy.
So what we're going to do today is the students are going to present to you what they've learned from your thoughts and reflections. So here's the course on one page. We had a few weeks on.
You said we covered.
Okay.
Yeah.
And so we've organized into country pairs so that there won't be 6, but there'll be 3 presentations. Makes it more manageable. And Shelley and Andrew to your left are going to start with some larger overviews about the readings today. So
what's my role?
to listen and comment.
Okay.
Would you like another role?
No.
Is that okay?
Just wondered how much talking you want from me.
So why don't we hear them, and then we'll have some discussion, and then we'll hear from each of the 3 pairs and have discussion as we go along.
Right.
Okay? Great. Good.
Hello, everybody. How's everyone doing?
Well.
Sweet. So, can everyone hear me okay?
Yeah.
Just like make a sign of like I start mumbling or whatever. So today we're going to talk about lessons for American healthcare and what have you learned. So first off, me and Shelley are going to give a general overview of the readings that Dr. Light assigned us, followed by sort of our take on the U.S. social-cultural context behind the healthcare system, and then we'll go over the 2 Fuchs articles on the recommendations for healthcare reform, as well as the cost control discussion. So on the handout, we have the Thorpe article, The Difference in Disease Prevalence as a Source of the U.S.-European Healthcare Spending Gap. So the main question that this article is trying to answer is, why does the U.S. spend so much more on healthcare per capita than any other European country? The U.S. spends at least twice as much as most of the European countries in the OECD. So what the study does is it examines differences in disease prevalence and treatment rates for the 10 most expensive conditions between the U.S. and the 10 European countries examined. So what the study finds basically is that there's a higher U.S. prevalence of costly conditions like heart disease and diabetes, which suggests that U.S. healthcare spending, a reduction in U.S. healthcare spending could be achieved by implementing measures that help to prevent or at least address these conditions. And so Thorpe offers sort of 2 explanations for this spending gap between the US and Europe. First explanation is basically Americans are just sicker. The US population has a higher prevalence of obesity as well as smoking rates, which are both linked to chronic conditions like diabetes and heart disease. So he calls for preventative policies to target these problems. And then he also talks about how the spending gap could be also due to sort of the different disease treatment philosophies that the US and the European countries share. So the US has been shown to be more aggressive in detecting and treating mildly symptomatic or asymptomatic conditions. For example, Thorpe harps a lot about how the US detects twice as much cancer compared to Europe, and that can't possibly be because Americans have twice as high cancer rates. But at the same time, this sort of aggressive treatment that the US does could also achieve a reduction in healthcare spending, because if you do detect things like cancer early, then you can forego the costs associated with long-term chronic care. So that's sort of like a complex interaction. So basically Thorpe is saying that we need to address the differences in both the underlying health status of these different countries as well as the differences inherent in the medical practice patterns.
So, in conjunction with that, there's another article by Massey, which is called Globalization and Inequality, Explaining American Exceptionalism. So, whereas the first article, you can kind of say that that inequality in the U.S. is due to the fact that Americans are sicker in comparison to people of other countries. The Massey article argues that America has more inequality because there are less social supports provided, and so therefore the poor people are allowed to kind of become more unhealthy and are therefore forced to use more hospital services and therefore increase healthcare expenditures. And that was kind of the take that Professor Light took from it. But looking at the article, Massey says first that globalization has increased the pressures for inequality around the world. Since the 1800s, there's been kind of an informational exchange throughout different cultures. And while it's a sharing of information and people and resources, it's also a world where there are limited resources, which means that the people who end up having the resources become more wealthy and more advantaged socially, economically, and then the people who don't have resources end up becoming poorer and less healthy and maybe have less education, and so therefore can't rise up as well as people who are in a better position resource-wise. It's interesting though because Massey takes on, I think, a very biased perspective, because he says that the reason why there are less social supports is primarily because of the political polarization that's occurred, and that there's kind of over time been a lack of efficient redistribution of income, meaning that for different reasons, for instance, the fact that the labor movement has never achieved the same level of success in the United States as in other countries, or the fact that the minimum wage here in the US has never been high enough to provide a sufficient standard of living for families of one that have one worker. Those are all kind of things that have come about because of, he argues, because of the legacy of race in the United States, and also because of the role of money in the United States. He says that because of the New Deal and LBJ's Great Society, there was great support for kind of increasing social services. But then over time, with Republican administration, there's been less emphasis on kind of progressive taxation and allowing for public service employment and things like that. So I think that from this article you can see that the United States maybe does have less support for its individuals, but at the same time, I'm not sure that I would be quick to say that it's due to race or the role of money. But yeah, so it's just, I think these two articles present different perspectives on why is the US system more unequal than other countries. And Massey argues it's not globalization that's the baseline, because all countries have undergone globalization. But for the US, it's the fact that we don't have as many services as other countries do. And we know that because we've talked about kind of the long-term care services in Germany. We've talked about the chronic care, disease management programs, and things like that. So it's an interesting argument. Next, we'll be talking about, this isn't on the handout, but we kind of thought, you know, we're going to be talking about United States healthcare reform, and we're going to be comparing to other countries. But there's got to be something different about the United States. We know that Barbara Starfield, when she came into class, she said you can kind of do all the cross-country comparisons you want, but at the bottom line, countries are still really different based on kind of their historical, social, cultural backgrounds. And so we were trying to think, you know, what makes the United States different? So I think Andrew wants to.
Yeah, so we're basically just going to give sort of our own general overview of what we think is the unique U.S. social-cultural context that involves healthcare here. So first off, there's this hovering specter of individualism. You know, the founding of America. It's all been about the individual pursuit of happiness and whatnot. A lot of emphasis on self-sufficiency and less about reliance on government. And this sort of ties into how America has also a lack of sense of sacrifice for the greater good, especially when it's us that's being affected. Whenever, say, like we come down with an illness or a family member comes down with an illness, cost control is the last thing on our minds. You know, whatever it takes to get our family member or us back to health, that's what we spend. We don't think about the big picture in terms of how is it going to affect the rest of society. And so this is sort of in contrast to the sense of solidarity that we've seen in countries like Germany and even France, where, you know, the sicker you are, the less you pay. Also, the U.S. has a highly heterogeneous population. It's not like Sweden, where a lot of the views and cultural values are the same. You know, we're just like a melting pot of just various cultures, and with that, you know, we have a rise of a lot of interest groups and stakeholders that all want their voice and opinions to be heard and fulfilled in the healthcare system. So you have this resulting process where it's hard to compromise effectively when dealing with the ongoing reforms that are going on right now with the American healthcare system. So Shelley's going to talk about some other points.
A couple others we were thinking about were kind of the emphasis on technology, and that anything that's new is automatically better, no matter how costly it is, and no matter like how much research has actually been published and released. And I think that this is probably true, probably for a lot of people all over the world, not just in the United States. The fact that, you know, something that's new and that's cutting edge and that scientists of the modern day have come up with, like that must be better because our science is always improving and improving. But I think only in the US, or in comparison to the countries that we've studied so far, there's been so much emphasis on using whatever drugs are available right now and not taking the time to see, is this really cost effective and is this really going to be marginally beneficial or not? And then also this idea that patients know better than the doctor. It's funny because I've shadowed at Stanford Hospital sometimes, and you get some like really educational patients, and they'll come in even with their laptops and be like, so I Googled my condition and I think that these are the drugs that I would like to take and this is the treatment that I would like to have, and the doctor's just like, well, hold on, I haven't even examined you yet. Let's just see if you really do have the condition. And I mean, it's true that accessing information is possible all over the world, but we know of some countries like Germany where I think it's Germany and Canada, where there isn't direct to consumer marketing of pharmaceutical drugs. So there isn't this emphasis on like letting the consumer be able to pick and choose what treatment is best for themselves, but that they really do rely on the physician and the hospital to choose for them what the best care is. And I think oftentimes patients wanting to kind of manage their own care does lead to increased costs in our healthcare system. So moving forward, well, those are just some of our ideas, and I think when we discuss more about the healthcare reform within our countries, you guys can add more things onto what you think of the U.S. mentality. But we're going to move forward to the Arrow and Fuchs article that provides 8 recommendations for healthcare reform, and those we've listed on your handout, just so you can especially refer back to them as we discuss with our country pairs later.
Why don't we just pause before moving on to the healthcare system about, in a way, a very cogent first part of your presentation about how America is different, and get some comments on that. And then we'll move on to healthcare, which actually is a repair shop, usually after that. So what did you think of the characteristics? Would you like to amend, elaborate, or add to them? What are your thoughts?
Well, I think they're on the right track. America is a different country than the countries of Western Europe or Japan. And I think one needs to go very deeply into the history of countries, the other countries and our country, to understand the basis for the difference. One way of illustrating it is with a famous exchange that took place in the Kremlin between Lenin, who was at that time the dictator of the Soviet Union, the predecessor of Stalin, and there were a bunch of Western intellectuals visiting Moscow at that time, and this became known as Lenin's question. Now, some people think I'm talking about John Lennon, but no, this is a different Lenin, L-E-N-I-N. And Lenin's question to the Western intellectual people there at the time was the following: that according to Marxian theory, socialism should develop first in the most advanced industrial country. The way Marxists saw the historical process, first you had industrialization, and then at the climax of industrialization you had socialism. And why is it that the United States, which is the most advanced industrial nation, has virtually no socialist party to speak of, or socialist movement? There was nominally a socialist candidate sometimes, but very weak and very ineffectual. So he was correct in his facts, and his question was why? Why is that so different from what Marxist theory would predict? And there were, of course, different answers provided, but H.G. Wells, famous British writer, gave what was the cleverest answer. He pointed out that there wasn't one party missing in the United States, but there were 2 parties missing. Not only did they not have a socialist party, but they did not have a conservative party in the sense that these other countries had a conservative party as well. Conservative in terms of the traditions and the attitudes toward the people and so on. In the United States, politically, what we had was in Europe, what you would call in Europe, 2 wings of the Liberal Party. The Democratic wing was kind of the left wing of the Liberal Party, because in these countries they also had a Liberal Party, and then the Republicans were kind of the right wing of the Liberal Party. But neither of them were like the socialist parties of Europe or Japan, or the conservative parties, because the conservative parties were also very much in favor of various kinds of social legislation. They saw that as part of the way you run a country and the way you govern a country, whether it was the Tories in England or Bismarck in Germany and so on. These were conservative people. So here, you had no pressure from the left, from the socialists, because they were practically non-existent, and you didn't have the conservatives, so you had only a liberal party. It's interesting, I've just started to think about, if you think about what's happening in England now, the two parties, the two main parties, the Labour Party and the Conservative Party, which used to be really, like the Labour Party was the Socialist Party, and the Conservative Party was the heirs of 19th century conservatism. Now they're beginning to look more like America.
Yeah.
The Labour Party looks like the left wing of the Liberal Party, and the Conservatives look like the right wing, but they're much more like American than they used to be. So what does this mean? This means that those countries came out of a historical tradition which goes back to feudalism. And then I'll just comment on one other thing, which is the distrust of government, which tends to be stronger in the United States and not so strong in many of these other countries. If you think about feudalism, and I don't know how much history you've read and so on, so maybe I'm talking past you or under you or whatever, but in feudal societies, the government is often seen as a protector of the people. Government came in and put in rules and order and protected people against the feudal society, which was one where the lords and the people on top ran things, and the serfs and the other people were underneath. So government isn't automatically assumed to be bad. America was created as a revolution against government, against the British government that was putting taxes on them and were doing other things which they didn't like and without their consent. So you have an entirely different historical basis for the different societies, and I think a lot of the explanation for the differences in approaches to medical care can be found there.
That's really good. It reminds me of Margaret Thatcher, the sort of great world champion of conservatism, came over here. She was on a conservative TV show being interviewed, and she said, I understand you have then, I think it was like 40 million people uninsured. He said, oh yes, we believe in private enterprise and volunteering. She said, well, I think that's appalling. And then she scolded her host for the very idea of being a conservative and letting working people get sick and not get care. I mean, good Lord, how can you do that? So that was, she was always talking sort of the way I'm talking, very, aggressive in your face. This is absurd, and how can you do that kind of tone? So as the leader of the conservative European movement, she fits right in with your story.
Let me just make a methodological observation. When you start talking about explanations, you have proximate explanations, and then you need to go more deeply to get more fundamental explanations. For example, to say that we have more inequality in the United States, which is a true statement, inequality of income and other inequalities, inequality of access to care and so forth, and to say it's because we don't have some social legislation to provide that, we don't have those programs. That's a very proximate but inadequate explanation, because you really want to explain why you don't have that legislation. It's almost obvious, it's almost tautological that if you don't have income support programs, you're going to have more inequality in income. But that hasn't really explained much. What you want to explain is why you don't have income support programs, and so that kind of methodological point is something you want to keep in mind as you try to seek explanations for things.
So we turn now to what we're calling the Arrow essay, but Dr. Fuchs was the head of the program behind that article and who wrote the article.
Okay. So we'll talk about the aforementioned article, Tools of 21st Century Healthcare System, Recommendations for Healthcare Reform. So this was a series of 8 recommendations made by the Fresh Thinking Project, which was spearheaded by Dr. Fuchs. So I'm going to go through the first 4 recommendations and show them go through the last 4. I'm going to pull from the different countries we've studied just very broadly. So the first recommendation made is replacing the current fee-for-service payment system with a payment system that encourages and rewards innovation and the efficient delivery of quality care. This new payment system should invest in the development of outcome measures to guide payment. And this recommendation sort of is reminiscent of how the UK is paying based on target-based performance of physicians and looking at health outcomes of the patients, as well as Germany with their disease management programs. The second recommendation is for the US is that they should establish a securely funded independent agency to sponsor and evaluate research on the comparative effectiveness of drugs, devices, and other medical interventions. So the country that's gone farthest along with this is the UK, which has NICE. I believe we talked briefly that Canada also had a comparable agency, although the name honestly escapes me at this moment. The third recommendation is the simplification and rationing of federal and state laws and regulations to facilitate organizational innovation, support care coordination, and streamline financial and administrative functions. So several of the countries that we've seen offer different ways of doing this. We've seen in Germany with the disease management programs that's really tightening up care and increasing efficiency and coordination overall, as well as with the government centralizing sickness funds, or creating the central agency that the revenues of the sickness funds go into, so as to standardize payment. And we also see with like Sweden, we have the coordination of councils and the federal government handling the setting of the basics benefit package, so you have that sort of streamlining of healthcare there as well. And the fourth recommendation we have here is development of health information technology infrastructure with national standards of interoperability to promote data exchange. This, I feel like this is a fairly slow development. A lot of healthcare systems are still on paper and whatnot, so this is more of something that all countries could work on, and will be an ongoing challenge.
The next one is to create a national health database with the participation of kind of everybody who's involved in the organization, delivery, and financing of healthcare. And also to make that information available to researchers. And I think the idea behind this is the importance of creating kind of a national standard for treatment for different conditions to ensure consistency and comparability. I think that we've talked a lot about how some countries have more standardization of treatment than others, and in the US we really find that there is a huge variation, what not with all of the kind of the convoluted financing structures and the payment structures and the delivery structures. You can also expect that on the side of the physicians, that if there isn't really a sense of coordination, there isn't going to be a sense of coordination for patient care either. And the next one is identifying revenue sources to subsidize healthcare coverage with the goal of ensuring all Americans. I think a lot of the healthcare reforms now realize, of course, that there are millions of people who are uninsured, and they seek to kind of expand Medicaid programs, Medicare programs, the public programs. But this won't do anything if you're always expanding to kind of contain costs, which is another issue that we definitely have to focus on. And so I think this is a really good point of just kind of identifying where you can get financial resources from the programs that you already have. So in the article they talk about how there's an exclusion, a tax exclusion on the employer-based health insurance, and I think we've read in another article that is actually like $200 billion of money over 10 years that the United States could be fundraising to fund for healthcare or for healthcare expenses that we don't have right now. And so looking at other countries, we can see how Germany has an earmark tax for the elderly, and how the UK, another thing that he talked about was putting a cap on resources and like working within a global budget also to contain costs, and so we know that is characteristic of the UK system as well. Another point is to create state or regional insurance exchanges to pool risk, and also to provide a standard benefits package. There's so many Americans who are working, but who work in kind of small employee groups or who are self-employed, and so they can't afford those high insurance premiums. But if they can kind of pool together like the larger employee groups, then they can afford to have access to health care. And this is like really reminiscent of Germany, right, with the sickness funds that are based on the occupation. And again, I think this is significant because most of the uninsured are people who are working who just can't access the care because it's still really expensive. And lastly, they talked about creating a health coverage board with broad stakeholder representation to determine and periodically update the standard benefits package. I don't know that we've necessarily talked about kind of an independent board with other countries, but we've talked about how Sweden and Canada have the federal governments that will determine the standardized package and then go from there within the provinces or the councils. And I think we've talked a lot about how the United States kind of care is based on whether you can afford it or not, and not based on the need. And so, like, I think it might be better to allow everyone to have the basic package of care and then see what happens after that, instead of just going from how much can you afford right away and not giving any care to people who don't have sufficient resources. So those are the recommendations. I think they're pretty comprehensive, and I guess as we talk later about comparing countries and how we can learn from them with the United States, I would definitely refer back to them. And then just moving from there, we wanted to talk about what are some of the design flaws of the US healthcare system. Professor Light always kind of talks about, it's important to look at the actual design system, and even if a system is running really well, it might really be founded on kind of ineffective, inefficient principles. And so looking at the US, what could we improve on that kind of design level? So first, we're talking about access and equality. I think the three main things that most of the reforms have been talking about now are access, cost, and quality. And so with access, we've talked about why is the United States basing their approval of insurance on pre-existing health conditions when most other countries don't do that. And also I think with access, sure, we have these public insurance programs, but the kind of ways that they're delivering and providing care are complicated. For instance, Medicare provides care for the elderly, but Medicaid does too. And even though Medicaid is supposed to be a program to help low-income individuals, most of the resources actually goes to support the elderly. And so why is that the case? And couldn't more people of low income be helped by the Medicaid program? And so yeah.
Yeah, so regarding design flaws about quality in the U.S., the U.S. is notorious for its lack of integrated care. We're sort of known for having a highly fragmentary healthcare system. So I think there was an article last class where the U.S. is actually has like a high percentage of errors made during coordination, like are the results, there are mistakes made on diagnostic results, or specialists aren't coordinated correctly with the referring physicians and whatnot. And this also relates to how there's generally a substantial variation in patient treatment. So there's, like other countries like the UK, there's like no standardization of how doctors are supposed to treat certain conditions. They sort of have free reign over that. So, and the problem is with the US, it's all about using the latest the cutting edge technology or tests or whatnot, but they may not necessarily be the best. We often don't wait for such relevant research to come out, so that can lead to a lot of cost increase. It's a big reason for sort of like the exploding costs in the U.S. healthcare system. So that also leads into sort of the third main category of design flaws, which is cost control or the lack thereof in the U.S. healthcare system. So the U.S. is largely fee-for-service payment. So we've been bashing that a lot throughout the class. Basically, there's no standardization. So it's like the doctors are paid not for how well they're treating the patients, but they're paid for how many services they can offer. So naturally, it's this problem of quantity versus quality. And also, the U.S. has a highly decentralized payment system. We have hundreds, if not thousands, of insurance companies, and with those thousands of insurance companies, we have a million different plans that all pay doctors differently. They cover different services. So it's just this giant mess where the doctors are stressing because they can't get the payments that they think they deserve from the insurance companies. And of course, the high administrative costs that are associated with maintaining such a large number of insurance companies and making sure that billing is collected from all of them in a timely and efficient manner. And also, this is something we didn't talk about before, but something I thought was interesting is emergency care. So in 1986, there was the Emergency Medical Treatment and Active Labor Act passed. And basically, there was this mandate that said that anyone who comes into the emergency room can get that care as long as they have need, regardless of if they have insurance or if they are willing to pay. So it's basically this unfunded mandate that has sort of become where the go-to place for the uninsured. So we kind of do have universal health care in that sense, in that all the poor and the people who don't have insurance, they go to the emergency rooms. And so what we've seen in the years since that's passed is a lot of hospitals have had to close down or merge. Yes?
But you're saying the problem is the cost. Do the patients still have to, do they still get the medical bill, and then if they can't pay it, the hospitals have to deal with it? Is that what happens?
Yeah, that's basically what happens. It's just cost shifting goes to the hospitals and then insurance companies.
The mandated treatment that was silent about billing.
Yeah.
A telling omission.
Yeah. Yes.
I'm sorry, do you know, or any of you know the history behind that? Because it seems like that's sort of, since it was passed, there was some sort of sentiment that universal care was important. And so, like, where is that coming from within our system?
Oh, well, there was a study just the year before that got tremendous response, where a physician compared emergency room to emergency room ambulance deliveries, and how many times an ambulance pulled up and was sent away because the patient inside the ambulance didn't have insurance. And actually, a third of the turnaways were at university teaching hospitals. Anyway, it really caused a storm, and this is the result.
I have a question for Dr. Fuchs. And it's related to this, like, emergency care and stuff, and like raising costs. In your Huffington Post article, you said that out of the 4 forms that you listed, you purposefully left out universal coverage because it would increase costs for, like, right now, I guess. But I was just wondering, like, if the current
which article?
The Huffington Post article that you had, it was titled.
That might have been Huffington who left it out, because I believe in universal coverage.
Okay, I think, wait, let me see. It said, one important omission from these 4 reforms is a proposal
Oh,
for.
oh, right. I
Yeah.
said, yes.
So-
The background on that is that things are, at the time, looked very dicey for healthcare reform, and they still look dicey. I mean, it's not a slam dunk that it's gonna get through, and if it does get through, it's gonna probably get through in a very heavily compromised and watered down form. And the reason why I wrote that piece was, let's see if we can't agree that there are 4 things that would be highly desirable, because none of the bills now propose universal coverage. So it wasn't as if I was taking it out of the picture. I was just acknowledging that I was not putting it in for basically because it didn't seem like it had any chance of getting through. Nobody's even suggesting that we have universal coverage now.
Oh, that's a telling point. That is a telling point.
Oh, yeah.
Yeah.
And so that's why I put those 4 in. Was that the thrust of your question?
Yeah, so I was just wondering, like, if we're only having these, like, incremental changes, I guess, it seems like that would drive up costs more than doing a large overhaul and getting universal coverage. I guess, like, what's your opinion on that?
Some of them would be cost increasing. Some of them might have a favorable effect. For example, if you have well-running insurance exchanges, then it may be that you'll be reducing the administrative costs in getting insurance out to the public and making it, in that sense, more accessible. So that might have a somewhat favorable effect. If you were to eliminate or reduce the tax exemption on employer-sponsored things, that could have a favorable effect. Because that, now because of the tax exemption, the people at Goldman Sachs have health insurance policies that are $40,000 a year, but they're tax-free. If they had to pay taxes on them, they might think, well, maybe I could do with a $30,000 policy or something like that. So it could go either way.
It seems like one challenge is sort of balancing what part of the system can be changed and which parts are so embedded currently and part of our culture that they can't be changed. Do you see the fact, we talk about the flaws of our employer-based system, what parts of that do you think can be changed, and what parts do you think are so embedded in the way that we do things now that you can't change it?
Very good question. And I think it has to be answered in terms of political feasibility. Very often when I go out and talk about healthcare reform, the first thing that people throw at me is, well, what you want is not politically feasible. And what I throw back at them is there were lots of things that weren't politically feasible until they were. In other words, circumstances change. Have you ever heard of the Emancipation Proclamation, the freeing of the slaves? That was not politically feasible until it was. And then, you know, we decided because of the war situation and so forth, he could get away with it and that it would be a good thing to do. For most of our history, we did not have a strong central bank like the Federal Reserve Bank, you know, but then it became politically feasible. For a long time, we didn't have Social Security. We didn't have any kind of retirement, assured retirement income for older people. And then in the 30s, it became really feasible. My favorite example now is $1 trillion to bail out financial institutions. I assure you that a year and a half ago or 2 years ago, that was not politically feasible. All of a sudden, there was a financial crisis at the end of 2008, and within a matter of weeks, Congress passed $1 trillion bailout for financial things. So I don't despair of good things ever becoming politically feasible, but I recognize that at any particular time, it may not be possible to do certain things. Yeah.
Really interesting answer. We need to wrap up this and move on to the countries?
Yeah, it's just so really quickly, the last thing is Professor Light included another article by Mr. Fuchs about cost shifting and how there are a lot of ways that reforms are proposing to change the healthcare system, and while they might increase equity, they're not really containing costs. So he throws out some ideas of subsidies, employer mandates, and prohibiting health insurance companies from basing enrollment on health conditions. Yeah, those things might be better for kind of access, quality reasons, but they definitely still require a lot of healthcare expenditures. And so he talks a little bit about what are the reasons why the healthcare expenditures are so high in the United States. So there's high administrative costs. We talked about how so many of the mechanisms that we have are really inefficient and complicated. We have a high proportion of specialists to primary care physicians, which we've talked about before. We also have, I had never heard of this phrase, but a high standby capacity. We have a ton of expensive equipment, but we don't really use all of it. Why do we have so much?
A lot of empty beds.
Exactly.
Yeah, so there's also, we don't have a limit on spending for healthcare defined by most private and public insurance, like no budgets or budget caps. There's also a lot of administrative and legal costs that arise from malpractice claims here. Doctors are notoriously not protected as much as other countries. There's also inadequate social support, which necessitates more hospital use by the less healthy poor. And so drug companies are allowed to charge really high prices, which refers to the whole world subsidy effect, where pharmaceutical companies charge more in the US compared to other developing countries that can't actually pay that much. And also physicians have higher incomes in the US and thus have little incentive to practice cost-effective medicine. So those are the main 8 reasons for our out-of-control costs. So I'd like to take this time now to sort of transition, now that we've collectively provided a framework for thinking about how different countries we've studied can help us understand how to reform the US healthcare system. I guess we'll break into a discussion now about
Okay, well, this has been really great. Thanks so much for pulling this all together. Did I remember we were going to start with Canada, Sweden? Is that right? Okay, so what are some of the thoughts of the Canadian-Sweden pair about these ideas and about the framework provided?
Okay, well I guess we'll start with talking about Sweden a little bit and what possible lessons the US system could learn from the Swedish system. But I think in particular with Sweden, it's important to realize that there's such cultural differences between the two countries that any comparison should be looked upon with high caution. In particular, we saw that Sweden, the regionalization of the system and splitting it up into county councils and giving the county councils a lot of freedom to set the healthcare systems within the small councils worked pretty well. But then again, Sweden has a lot more equality and homogeneity in the culture and in the overall population. So the question is whether a state-based system would work in the US. Probably not as well. Also, like we were talking about, in terms of the cultural differences between Sweden and the US, we have a distrust in government more than Sweden does. And also, we've seen in some of the reforms in the current debate, a lot of them have been trying to avoid raising taxes, but that's something that the Swedish system depends upon, high tax rates. So those are some of the questions that you have to ask in terms of Sweden and the US.
Can I try being devil's advocate? Mm-hmm. Okay, so I wonder if I say, people really like Medicare. It's a single-payer, universal system for the elderly. And while people are not all that keen on Medicaid because they're not that keen on the poor, even though it's a country that produces poor people, Medicaid's pretty well established too, and CHIP, which is for poorer kids, is actually, I would say, reasonably popular. We don't care about the parents, and especially the men. The men really get the short end, but the kids the program for the kids is pretty popular. So I mean, how about that as a challenge? That is actually Americans aren't all that favorable towards even a single-payer universal system. And anyone else can jump in. I don't need to just sort of put this to Anne, but to anybody.
I was gonna say with Medicare though, it's also running out of money, I guess, like as our population's getting older, and so I think as an example of a single payer system with universal coverage, I don't think it's a well enough maintained system to keep it sustainable. And so I think that's something that's needs to be seriously considered when comparing the structure of Medicare and CHIP, I guess, to the system that Sweden has.
Okay.
I think people are also skeptical. Even if it works, I think people are there's sort of this attitude of complaining, the same distrust in government we keep talking about, that you can say from a sort of a high level that it works and it covers many people and they get this kind of care, but I still think there's distrust in the system, and that when you, that's sort of because we have so many interest groups and people that have a say in it, that if you were to broaden that and say we're going to have Medicare for everyone, that people would freak out, and that's sort of our attitude from it.
I have to come in on Sweden with one thing which is much in the news these days, and that is mammograms. And what should the government pay for, or what should insurance pay for mammograms? Do you happen to know what the situation is in Sweden? No. I'll tell you what it is. The standard protocol for Swedish health services is a mammogram every 2 years for women 50 to 69.
That's it?
That's it. Unless there's family history or some special thing. No, it's not an iron rule, but it's the standard.
It's for people with no other risks and no history.
That's right. That's the standard.
Right.
And I started teaching my students that 25 years ago without knowing anything about the biology of medicine or anything like that. I figured the Swedes are pretty smart. They're good scientists. They figured out, and they have, as a national system, they have every reason to want to engage in those things, those screenings, which would pay off for the system in terms of catching things early and so forth and so on. But now, in the United States, even after study after study after study has sort of recommended something along the same lines, starting at 50 and once every 2 years, the uproar and the backlash and the hypocrisy of the budget hawks on the Republican side who supposedly worry about spending and so on. But why does Sweden get away with that? And the United States couldn't get away with once every 2 years for 50 to 69.
Well, did Sweden start like that? I mean, Sweden started with those guidelines, right? Whereas the US started
they didn't come down at Mount Sinai. I mean, presumably at some point they had to create them. I don't know what they had before, but probably once the technology became important, mammography, they probably did some studies and they concluded that that would be a good thing. To say they started with it, you may be right, but you mean because the difference is now we have to change.
Right, exactly. We started with age 40, and so it's regarded as a step in the backwards direction.
They tell me that the younger women have more dense breasts, but I have had no recent experience with
that. Victoria's next, but one thing that comes to mind is your very wise comment about the feudal historical tradition. So in Sweden in particular, one thing we learned historically is that the Swedish system really grew out of a public health service. which would mean a long tradition of public health standards being set by public health officers who do research. Here, as you know, we do more health services research by far than any other country, but the frustration of those of us who do it is that no one listens. No one listens to us.
Right.
Victoria.
I was kind of going back to what you guys were saying about inequality in the U.S. and then thinking about what you just said about like the backlash against like mammograms and like changing the dates. But it seems like in the U.S. like we're really willing to allow certain inequalities but not others. So I don't know. I think the whole Massey bringing up race as like a legacy is interesting, just because it doesn't seem like we're really individualistic, but only about certain things. So it seems like in the U.S. the biggest problem is picking out, like we don't see universal coverage as like the main issue, but God forbid like one woman misses like her mammogram and gets advanced breast cancer and dies. But the fact that there's all these poor people who don't get care doesn't also factor into our minds. It seems to be very segmented in even how we think about healthcare and how we think about, because to me it just, like I think we all agree, like it makes sense to have universal healthcare because then everyone will be covered and be able to manage everything. But as a nation as a whole, it's still very like, well, certain people don't deserve, like certain people didn't work hard enough, or certain people don't deserve certain aspects of healthcare. So like a question for you, I think when you were talking about inequality in America, like, and the lack of social networks, like why do you believe that we don't have certain social support for certain things? Why we don't have the social support needed to cover, to make the poor not sicker?
I'll mention one paper by Kate Bundorf and myself, and what we looked at was survey responses, but trying to probe more deeply into people's attitudes and beliefs about national health insurance and universal coverage. We want to see how deep does that go, because if you just ask the question, do you favor people getting it, you know, a majority typically say yes, right? Most surveys say yes. And what we found, if you probe more deeply, we think, is there are strong biases in a large part of the public, first against African Americans, and secondly against immigrants. And underneath the weakness in real political support for national health insurance, we think that's part of the picture. That's not the whole picture, but we think that's definitely part of the picture.
All right, thanks. Talking about Canada, we had the sense that Canada was the stitching together of provincial plans,
Yes.
then glued by support from the federal government in 1971, was it? Anyway, in the 70s.
It came in two parts, hospitals first and then physicians.
Yes, right. And that there hasn't been that much discussion here about how, regardless of what is passed federally, there'll still be a lot of stitching together going on. There are large state differences in culture, in affluence, in approaches towards taxes, views about the poor. For instance, I'm from a state that's surprisingly sympathetic towards both African Americans and immigrants, and has, I don't know if you know this, but
Which state is that?
New Jersey.
New Jersey.
New Jersey has universal health access to all hospitalized services, regardless of ability to pay and regardless of legal status. But my neighbors don't even know that's true. But it is true, and the people in the immigrant community know it's true, because I've been studying them.
Here's something to think about, just a fact, I won't try to explain it. When the Clintons tried to put through some kind of universal health care, national health insurance, the bill was 1,300 pages long. Now, in the Senate, they've gone one better. The bill that Reid has introduced, I think, is about 2,000 pages long. I had a friend of mine was the head of the Health Council in the province of Manitoba, which is one of the Canadian provinces. and I asked her to please send me the legislation that established the Manitoba health insurance program, right? It was 56 pages long, and it was in 2 languages. Now just think about a country that can get by writing a bill which is 23 pages basically long, and we have to have 2,000. If you want the explanation, the immediate explanation, I think you just look at the law school here and the huge dormitories that they've now built for the law students. We are a very, very law-minded, litigious, and we take pride in that. We say we're a nation of laws, not a nation of men or women. But we can go to 2 extremes. It's an extreme. If they can do it in 23 pages, we don't need 2,000 pages.
So do you think that the US can kind of mimic that to the Canadian system with a lot of control on the local level, or do you think the fact that our states are so different from each other and there's so much inequality?
Oh, no. Let me tell you another thing about Canada, and that is the attitude toward government. It is not unusual for some of the leading graduates of the leading universities in Canada, whether it's University of Toronto or McGill or whatever it is, who go into government. They go into provincial government. Now, I taught at Stanford for many, many decades. I don't think I ever had a student, and certainly not a leading student, who said their ambition was to go to work in Sacramento. So you've got and they have good government, basically good government. In the United States, at this very moment, there are several ex-governors who are doing hard time in real prison. And there are several more who ought to be doing hard time, but they just haven't gotten through the indictment. So when you have this amazingly difference in the quality and the attitude toward government and so on, you can't, I don't think you could possibly imagine on a general scale reproducing the provincial approach here on the state level. Maybe Wisconsin can do it, and maybe Massachusetts or New Jersey, but I could name, I don't want to protect the guilty, to name certain states where I wouldn't trust them with a dime of money to spend on health care. Right?
One of our students went for a roads interview in Alabama and learned from the roads committee that there is no problem in access for health care in Alabama. There's no need for universal health care because everyone's taken care of.
Yeah.
So
yeah.
It's really great to learn that. Yeah.
Just to go back to Canada and the reforms that we were talking about, I think also a big difference between the two systems is how the hospital structure is set up. And in Canada, it's a lot of non-profit hospitals that provide care, whereas in the US that's not the case, and a lot has to do with the investments in the hospitals. And the same goes with how the doctors are paid within the two countries. In the US, like, a lot of doctors are paid, you know, their established pay is kind of whatever they charge their patients, and there's no real regulation of that. But in Canada, they're paid fee for service, but it's also capped. And so doctors are unhappy there about, you know, how little they're being paid, but it's still how the system works. Whereas in the US, I think if there was sort of a cap on the salaries of doctors and stuff, it would just be unheard of, because, you know, in the US you go to school and you go into a profession, and you work really hard in it, and you're expected to be paid very well for that. And so that's another difference. And you know, if the US were to move towards universal care, like, that's what are all the doctors going to say about cuts in their salaries and stuff like that too.
Now, what role do you think the rapid growth of for-profit corporations in the organization and management of services since about 1980 has played? If you look at, say, post-war 55 to 80, and then 80 to 2005.
Yeah. Hard to say. Hard to say. I certainly haven't studied it myself. The great majority of hospitals in the United States are still nominally non-profit hospitals. But they don't control the staff. The physicians who work in the hospitals are independent entrepreneurs. And depending on the hospital, they have a tremendous amount of influence on what happens in the hospital, what equipment the hospital buys, what staffing they do, and so on. There was an excellent book written many years ago by Mark Pauly, and the whole point of the book was that the hospital was the doctor's workshop. That a lot of economists go wrong because they think of the hospital like a firm, and that you can model it the same way you would model a firm in a capitalist system. But if you realize that the doctors have a tremendous influence over what goes on in the hospital, and the hospital is their workshop where they make their money, it gives you a different picture.
Let's move on to Germany and England. We focus more on England than the UK because they've now diverged some.
I'm going to have to probably talk.
Okay.
I'm sorry about that. But
No, it's good to have you here. Any reflections of last time? And
So we talked about England and Germany kind of together. We talked about how England started with kind of a centralized, nationalized government or healthcare system structure, and then Germany started with a very decentralized one with the sickness funds. But they both, in different ways, have kind of incorporated different aspects of market-based delivery and financing of care. And so, when we can talk about the different ways that that's happened, but for the United States, we thought that was a really important kind of insight, because a lot of the times when people talk about the US, it seems like it's an all or nothing idea, right? That like you either have completely socialized medicine where insurance companies and providers are all supported and funded by the government, or you have kind of a completely market-based system where everything's for profit or everything's private, and there's no kind of in-between ground. And I think that like just looking at England and Germany, you're able to see, oh yeah, there are different paths, and even between the two, they're completely different. So we looked at, do you want to talk about England?
Yeah. So basically with England, we've been talking about a lot about its internal market and how it does manage competition. And we were saying that there's a big lesson there for U.S. healthcare reform, that anytime you introduce some sort of market element in your healthcare system, you really have to be thorough in designing that market, testing it, and really thinking it through. Because of the UK, when they pushed the market, it was very half-baked, it was very premature, and so now they're constantly having to play it by ear. The market, in terms of health outcomes, the internal market that they have, is doing well, but then costs are also out of control, and the government is still sort of like trying to figure out sort of like what is their role, like should we have more control of that, trying to ease off, but again, they're just pouring funds into it, and it remains unclear whether that's actually sustainable. And so with the U.S. trying to implement like a health insurance and exchange market, it'd be good if they really thought that through, because that could just cause costs to soar even more.
And then I think as far as Germany goes, we discussed they had a really decentralized system with all the sickness funds that moved towards centralization with the creation of a central fund and risk distribution within those sickness funds and who they were covering. And we discussed a little bit how that reflects in the United States sort of different insurance plans and premiums that are around. But in Germany, it seems to be that there's there is a basic baseline of care provided, and that seemed like something that would be an interesting starting point for the United States, just to provide some sort of basis in terms of coverage that's offered. I think
think we discussed just access, quality, and cost, and how those varying things within Germany and in the United States. Shelley and I were pretty optimistic. We looked at Germany and thought it was a good model for the United States to see how you can take something that is decentralized and then work on various aspects of it to sort of make it a more central and universal system for more people, which I think is something that the United States, I mean, my personal opinion is should be moving towards. And Germany is a good example of how that can be done with a system that is not completely government controlled.
Now that's a really good comment, because I mean, it's taken them years to, it took them years to get the coverage packages more uniform and then to equalize the risk profiles and to consolidate. But they have steadily been working at it for about 40 years.
And then extending on what Leah said, I think another lesson that is really important is how they standardized the packages, but then they had the sickness funds compete for business. And I know that is on the basis of nonprofit, but using that that drive to compete against the other ones and competing for business rather than just pure profit, it's just could be a really good lesson, and something I think the insurance companies here could work on and learn from.
Mm-hmm. Yeah, and they've worked well in recent years to creating a very level playing field, so that the competition can only be about quality of service, efficiency, responsiveness. They're not allowed to cream skim, cost shift. They're not allowed to skimp on quality. So it's sort of forcing the juices of competition into superior performance and efficiency. While here and in some other countries, they're not so careful. In Switzerland, they're not so careful, for example. The Netherlands is another example of a country that's worked really hard to create a level playing field for competitors and not have them imbalance.
Going along with that, I had a question
Yeah.
for both of you. Germany was allowed to make these somewhat incremental changes to the framework that already existed, to the decentralized sickness fund model, but I think a big difference, obviously, is the not-for-profit versus for-profit model. So how do you think, if we were to try to use Germany as an example for how to make changes within a decentralized system, how you can do that when we have such an emphasis on the for-profit model? Could some of those standardization and leveling the playing field be used here the way Germany did?
Well, I think the rhetoric, the American rhetoric of competition leading to innovation and performance can easily be kind of harnessed with, well, you want fair competition, don't you? You don't want unfair competition. You don't want to have one basketball team have 7 players and the other have 5, or one have the hoop 6 inches lower at one end of the court and 6 inches higher at the other end, do you? And so it seems to me it actually can feed well into American rhetoric. So there's an optimistic.
I would agree with that. Yeah. It all depends on how you structure it, but it can feed into the American idea of choice. Some years ago, a colleague and I developed something called a universal voucher plan. Maybe some of them heard about it, read about it. And the idea is that everyone could enroll in a plan which would be, in the modern terminology, an accountable care organization. Right? So in any region there'd be 5, 6, 7, 8, 9, depending on the region. And you would be in that plan, at least for a year. Then you could go to another plan if you didn't like it. So the plans would compete on the basis of service and quality, and would get paid on a risk-adjusted capitation basis, right?
Yeah.
So it preserves the American ideas of competition and efficiency and so forth, but it does so in a much more structured, managed framework than just a laissez-faire type of competition. Yeah. So I think that's possible. In fact, not only possible, but as far as I could see, it's probably the only way that that America can go toward some kind of universal system, is by preserving this choice and competition model.
How would that fit with our current employer-based system? Like how do you reconcile those two?
In our view, the employer-based system would fade away.
Okay.
If you don't have the tax exemption, incidentally, it's $200 billion a year, not pennies. If you don't have the tax exemption, and you have the opportunity to enroll in the, not, you know, everybody can enroll, we don't think the employer-based system can last. We don't see any need for Medicaid. The whole idea of putting poor people into a different healthcare system, which they will be in or out depending on their income, that sounds to me like a terrible way to go. And there are many people who are eligible who aren't even in, who aren't taking advantage of the Medicaid program, and so on. So both of those would fade, and in our view, over time, Medicare would also fade away, because if a person is enrolled in a healthcare system and is satisfied with the care they're getting there, and they turn 65, there's no reason to say suddenly you have to be in another healthcare system. You would continue to be the same system that you've been in. So it would take care of everything. And here's a very interesting thing. I apologize, but I have another commitment that I'm going to have to leave promptly. There's a tremendous fuss and fighting now about whether people who are undocumented aliens, illegal immigrants, call them what you want, should get health care or not, and should get it through any government program, right? And the people in Congress are bending over backwards to make sure, oh, no, they're not going to get it, not going to get it. Well, I was presenting our universal voucher system, which incidentally is funded by a dedicated value-added tax, which is a sales tax on business. And I'm speaking to the California Medical Association in Southern California, a lot of conservative physicians there. First question I get in the question period is, what about illegal immigrants? And I answer it with a question. I say, are they paying the value-added tax? He says, yeah, they're paying the value. Then they're covered. And he sits down and no one else would, that solved the problem right there. As long as there's a feeling that they're paying the tax, then they're in the system. And it doesn't matter what their immigrant status is or the visa status or anything like that. And it's so simple in a way, and yet they're fighting over this, and they're bending over backwards to say, oh, illegals can't get medical care, which is ridiculous, because of course they're going to get medical care. They're going to get it somewhere in the county hospital or an emergency room or something like that. So, but it was very interesting to see these conservative Republican physicians just accept that's reasonable. They pay the tax, they get the care.
Well, thank you very much
I'm
for
sorry.
being with us. Oh, well, they're all Hub Bio majors,
Right.
mainly seniors. Actually, there's one we're persuading to be a Hub Bio major. So I think Philip's going to join. Aren't you going to join us? Well, he's thinking about it.
Yes. I'm leaving investment banking.
We've been working on recruiting him.
I see.
Investment banking.
You feel invested in the program?
Yeah.
Okay, good. All right, well, good luck to all of you.
Thank you.
Thank you.
Bye-bye.
For more, please visit us at stanford.edu.